Welcome to the Healthcare IT Today CIO podcast. I'm John Lynn, the founder and chief editor at Healthcare IT Today, and I'm excited to bring you the most practical healthcare CIO insights and perspectives. We know your job is challenging and we want to help you be more successful. And our guest today is Ray Lowe. He's SVP and CIO at AltaMed. Welcome, Ray.
Well, thanks, John. Longtime listener. Great to be on Healthcare IT Today. I love your messaging and Colin Hung. I'm an avid listener on the podcast circuit, so thanks for educating us.
Wow, I love that. Well, and this really came out of you winning the most innovative CIO of the Year award that we gave out at HIMSS, recognizing all the great work. So I'm excited to have you on to talk about that work. So congratulations and a well-deserved honor there.
Thank you. I'm really flattered to have received such an award.
That's awesome. Well, for those that don't know you, tell us a little bit about yourself and AltaMed.
Sure. So again, thank you for allowing me to be on Healthcare IT Today. Thank you for the Innovation Award and being able to talk about that. I've been the CIO here at AltaMed since 2018, and we've gone through a holistic transformation from the ground up. We're a large integrated provider network, and at our core, we're a federally qualified healthcare center. We treat over 500,000 lives, and most of those are low income, underserved, non-English speaking patients. We have elder programs. You also have a managed care solution. And we even have a small health plan as well inside of here at AltaMed.
Interesting. Well, that's a long tenure for a CIO. That's interesting. What do they say, 3 years these days, which is crazy to think about. But that's like it's quite a while. And I think it's interesting that AltaMed is an FQHC. And then also we utter Epic in the same conversation, which means it's not a regular FQHC. So talk to me about what it is being, what it's like for you being CIO at an FQHC and how that may be different than some of the other organizations. We've had a lot of hospitals, health systems on. How is that a little different for you as CIO?
Yeah, so it's interesting. So my DNA is I was at Kaiser for 8 years, at Providence for 3 years. I was at Dignity Health for 8 years. So that's a whole lot of 20 plus years of working in the big systems. And fortunately, through those different experiences and different leadership roles, coming into a much smaller environment, into an FQHC, which is not hospital-based, to your point as well, right? And you're now dealing with health equity gaps, non-English speaking, not acute care, more ambulatory care in there. So it really pivots and allows you as a CIO to see the impact of what and how you need to move ahead. The other complexities of an FQHC is we treat everybody and anybody independent of their ability to pay. Like in the hospitals, if a patient presents in the ED, there's EMTALA, right? You will see the patient, you will stabilize the patient, but we will treat our patients and follow our patients, providing primary care, dental, women's services, HIV services, et cetera, for that patient population. So it's a different perspective in there. It's really kind of a man of the people type of an opportunity to do the work. But when you kind of look at Epic and an FQHC, a lot of folks in the past, I think they've done more of a subscription model, a community connect of somebody in order to instantiate it. And fortunately, AltaMed had the size and the ability to actually create our own instance back in 2018, going live in August of 2019, just a few short months before the pandemic around there. And I think in Epic land, there weren't a whole lot of FQHCs. We're one of the largest in the country as we stand. So fortunately, we again had the scale in order to do it. But when you look at FQHC and you're changing into really what is a structured group practice. We have about 400 providers within our network. So how do you go to a group practice? Usually FQHCs, providers practice medicine, to the best of their ability, more of how they want to do it versus how do you really do those structured group quality measures, interventions, express lanes, and those type of things. So it's been very transformational.
Interesting. See, I've described FQHCs as kind of this hidden gem in healthcare. Do you feel like that is, and is it because you're able to treat that holistic population regardless of ability to pay? Or, what's your view on kind of the FQHC role within healthcare?
Yeah, I agree that FQHCs, I think, are misunderstood in terms of the work they provide. And we are the last area of support to the ED for primary care. And FQHCs were created in areas that there were health disparities, whether it be in rural cities or whether it be in rural countrysides, right? So for a lot of the lower income populations, they will come in and receive their care at an FQHC. What I find interesting is it's sometimes easier to pull a patient in to have them get a dental exam than have them come in for primary care. And what we
Oh,
do on
interesting.
that through medical dental integration, it's okay, come in and see our dentist, right? But at the same time, we'll do some preventive testing with them as well, or kind of get them enrolled for a follow-up one of our primary care providers, so we can really treat that patient, right, more holistically.
Ah, that's fascinating.
Yeah.
Interesting approach. And it actually brings up an interesting topic I wanted to discuss with you, which is kind of patient experience and, what patient experience projects are you working on and how has that changed over time? And, I think you have a unique perspective because like you said, they're lower income, they're multilingual, but, how are you approaching kind of this patient experience and how has it changed over time?
I think it's kind of a misnomer that people think that folks that are low income, that they're not cellularly enabled.
Hmm.
That's a fallacy. They may not have, the latest iPhone 15. They may have a 6 or an 8, but they are connected and they're jumping onto Wi-Fi that's out there. And when you're looking at how do you reach the patients, how do you have them understand on the patient engagement perspective? We've done a lot of the standard things that most systems would do with, a My Chart, your ability to do televisits,
Okay.
et cetera. But now we're actually going through another holistic transformation. And I think with the advent of AI and other opportunities that are coming in there, not only can we have more personalized care for the patient in their preferred language, that's important, not English, right? In our case, it would be Spanish. But then also, how do we present more information back to the care providers and do that linkage? So I'm really excited. We're again kind of doing a whole contact center up transformation. And of course,
Interesting.
Epic is the backbone by which we're going to be looking at their Hello World, their Cheers, et cetera, for outreach on there. But when I'm also looking at how does a patient engage with AltaMed through the digital front door, kind of through a voice perspective, and what I'm hoping for is more of natural language processing. So if you're a patient and you're calling in, I need to see a doctor for XYZ, it'll pull out that information like we're seeing in ambient clinical voice, and it'll help steer the patient either like through a symptom checker verbally, or potentially, hey, we can have you do an AltaMed now, which is an instant video visit, or you really
Okay.
need to go to the ED, right? Go to 911 and go to the ED, right? So I'm really excited about that space and that opportunity. Not that we lose a personalized touch, but that we use technology in a friendly way, to close the wait times, to close the gaps in order to serve the patients.
Well, and FQHCs have a different responsibility because you are responsible for an entire population. And to your point, you want them to come in, using your dental. That's fascinating approach. Like that requires a different patient experience as well, right? Because in many organizations, they're like, I have a 6-month wait list. I don't want anyone coming in. I think you have a responsibility to try to get them in, right?
Yeah, we do. Again, most of this is Medicaid patient populations in there, and Medicaid's tricky. Medicaid can change every month by your insurance provider. And in California in 2024, it's Medicaid for all. So there's actually a large growth of patient populations. In the United States, 20 to 30% of the patients are in the Medicaid space. So there's 300 million people in the United States,
Wow.
right? That you could do 20 to 30% of that. 60 to 90 million people are in this area that we serve. And then HRSA, which is the oversight group that oversees FQHCs, again, they look at how we providing the care, how we doing sliding fee scales, et cetera, on there. And FQHCs are provided grants that enable us to provide, this basically free care or near free care.
Yeah, it's amazing. Well, let's shift gears to my favorite topic. I want to hear what you think. I think you're interested in it as well. Is ambient clinical voice real or is it hype? Where are we at when it comes to ambient clinical voice? How are you viewing it? How are you approaching it?
Yeah, well, what I'll say again, listening to Healthcare IT Today, John, listening to your podcast, going right around HIMSS, it really helped me distill and understand where and what and how and who's who in the space. So thank you for providing that service to us. I actually sent that podcast out to my clinical leaders because this is unpacking it in 20 minutes. So thank you for that service.
Oh,
And
thanks.
I think like in the last year, it's really accelerated. Originally there was kind of more this, transcription, the DAX type of things
Yeah.
happening out
Even
there.
virtual transcription or
Exactly, right?
virtual,
Right.
scribes.
Exactly. Or you have the scribe, in the exam room. And, you what we've seen at a bridge, what we've seen at Nobula, excuse me, and, what you say at Microsoft and the Copilot, they've really advanced it from just somebody behind the scenes, not in the room with you, where it picks out the language, and actually saying what is the subjective part of that SOAP note. I think in the past before, the docs had to kind of get this whole long transcription thing in there and do a lot more review. And now it's much more targeted and specific to what the patient is seeing. So I think it really improves the provider quality, the provider timing of understanding what the patient is. And because now that we're able to do it on a mobile device as well, it's not intrusive, right, to the patient. It's kind of just listening there as well. We should let the patient know that we're talking to them, in
Yeah.
that capacity. But it's a very friendly type of an engagement. They can talk one-on-one, more face-to-face, versus spending all that time, looking up at the monitor while they're typing in specific parts of the note.
Yeah. No, that is the evolution. The other evolution I'm waiting for is the EHR integration, which I think EHRs have finally woken up and said, okay, we're going to do this. Right?
It
Maybe
has to
that's
be
the
there.
evolution as well.
Yeah, it has to be there, that native integration, which I think is some folks are ahead of other ones in terms of it. That's really paramount for us, is that it have a native integration inside of for us to get for Epic, so that it flows seamlessly into the subjective part on there. Even extending it if you want to review it on their iWatch, et cetera, Limerick, those type of things. Also kind of leveraging those type of things. But that integration is really key. And folks are doing it, right? So it's really promising. I have another my annual physical coming up. My doc, who usually has a scribe, and I can't wait to go. Where are you on your ambient clinical voice?
Yeah, I've thought about just taking the ambient voice and having it create the note for me as a patient.
There you go. There you go. Right.
Having a solution like that. It's fascinating.
But when you
How are you?
talk,
Go
but when
ahead.
you look, but let's follow that a little further. So when you kind of think about that note as a patient, right? So what you just said, and kind of like a patient engagement, right? I don't know that we're there yet, right? But if we can, you recorded your note, right? And you're able to connect that into um, my digital front door, right, as a patient, right? And that file is then parsed and we get back to you with kind of the options on there. I mean, this is kind of a very cool space that I think will be developed in there in terms of, again, how do we help patients more so, or how do we, kind of get to them, because everybody is busy. But that's what I'm kind of really looking to happen in the next couple of years.
I mean, just following that pathway, right? And of course, this is all a bit of conjecture, but the technology is there to do this, right?
Correct.
Like, how does your front door work? I say I have a cough or cold, my knee hurts, right? Whatever, right? Like, they give a chief complaint, right?
Yeah,
But why shouldn't we just allow the patient to drone on for 5 minutes about what's happened, the history, this is what's happened, this is what I felt, this is how it evolved, right? I mean, that's what we do in the exam room,
exactly.
and so that could actually be a really interesting evolution of the intake process. So then when they get there, the data's already in there. That's interesting. Never
Right.
thought about it.
I think it's kind of cool, right? Hopefully we'll get there.
Yeah. How are you approaching it though? Are you thinking let's pilot it with a group of people? Let's try out a bunch of different solutions. Do you have a tech committee that's reviewing it? How are you approaching kind of this really fascinating technology that seems like it's going to have a lot of impact?
Yeah, so we'll talk more about on the provider ambient clinical voice, right? That's probably easier to land. I think that I think we're looking forward again in terms of that future patient
Sure.
experience. But
Yeah, yeah.
ambient
But
clinical
in the
voice,
ambient.
yeah, I have a team of clinical informaticists, physicians that are part of my team. We're doing basically a bake-off and usability of what's happening again between the big three that are out there and where are they. I mean, some are more nimble than other ones. I don't want to plug one vendor over another because I haven't made my selection on that yet around there. But again, that integration you're talking about is really key, right? And and that usability of that and how well does it work, and then also testing to making sure that it does on multiple languages, because there
Mm,
have been limitations where certain things can be done in Spanish,
that's
which
interesting.
has been a non-starter for us, right?
Sure.
So, looking for Spanish, we're looking for Chinese, we're looking for Tagalog as well, potentially. That's, Filipino. That could also be kind of carried into these.
Yeah. That's interesting. And the interesting part for many of them is the inner, adding in a translator. But I guess in your case, you probably have a lot of providers who speak it natively and treat them in that language, which is a different challenge altogether as well.
Well, we do, but we also have translation services, right? So we're able to do a split screen similar to this podcast, right? Where we'll bring the translator in with the provider and with the patient, whether it be in person or whether it be in a video visit. So you actually see the translator with the provider. So that's again really important to make sure that the patients understand, right, where we are and what we're doing. We don't want to
Sure.
rely upon another person in the room, et cetera. We know those are not areas you want to go to, but providing that care.
Yeah. And the ambient voice has to go through the translator, the patient
Right.
and the doctor. That's an interesting ambient voice problem. Fascinating. How about other AI projects? Are there other things you're working on or considering? We talked about kind of the digital front door dream, right? But what other AI projects are you working on or looking at?
So we're actually looking at a lot of what Epic is doing in terms of the AI functionalities. So part, automated in-basket messaging is
Mm,
something that we're looking at. But we're taking it further. We've done a lot of work in the value-based care and risk models.
okay.
So again, when we look at our kind of our patient population and our population health, right? So we've looked at how do we forecast, right? Patients in Medicaid, right? That ED admits per thousand. How we've created advanced planning risk models as well, so we know where the interventions need to happen, kind of with our care teams. And what we're looking for is, and we're hopeful and it's promising that clinical decision support will be there more at the point of care. Another thing we're doing in terms of Medicare patients is on HCC diagnoses is we're doing an integration into Epic, and it's going to be reviewing the coding that's being provided to the doctor to make sure we have the proper diagnoses. We've been able to bring in through Epic's claims loader the acute care, professional billing on there, and kind of wrap that into that technology with the clinical decision support. So it gives you that more comprehensive perspective of the patient, but then presenting that again to the provider.
Hmm.
And then back on the HCC thing, what we're doing as well is when we're going to billing and coding, we actually will do several reviews prompted by NLP to
Oh.
promote the coders, right? Are you sure this is not the code that you want to use, one,
Yeah.
two, three times to show that we're learning it. So there's a lot of opportunities, kind of an HCC, clinical decision support, risk stratification. Again, kind of being an FQHC is kind of very interesting, in terms of how we're approaching value-based care and making those impacts.
Interesting. I'm surprised you didn't say the letters. I thought that was the first thing Epic came out with was generating all these referral letters and stuff, which makes sense for generative AI.
Yeah,
Maybe you are, and you just didn't mention
yeah,
it.
yeah.
Yeah, I heard that Epic has 300 AI projects or something. I read some headline that I was like, wow, it makes sense. This is the evolution of what's happening. So fascinating.
Yeah, and I mean, Epic does it well, right? Judy Faulkner's committed to healthcare, to advancing these type of advances, right, for the greater health of all.
Yeah.
And
And in a safe way, I think.
absolutely, right? Like a mid-size health system, we're about 5,000 people. For us to be able to try to match what they're doing, we can kind of do, I think, things more in the fringes, more so versus kind of like diving directly in or pulling in the products, right? Versus trying to create all these things from scratch.
Yeah, fascinating. Another big news item recently that I'm sure you've seen and felt and is the Change Healthcare breach, and it's ongoing. It sounds like there's a second ransomware attack, etc. Not to dive too much into the details of it, but how do you think that experience, and it could happen to anyone, let's be frank, but obviously they're a very well connected, billions of transaction organization. How do you think that's impacted things in healthcare? And what do you think kind of the long-term impact of this incident will be on? I mean, and I think what's fascinating is it impacts cybersecurity, revenue cycle.
Right.
What do you see from it? What are your takeaways and kind of action items from what happened there?
Yeah, to me, it makes you really look at your third party vendor management, as well as your cyber, right? How were you able to, whether you were to modify it or whether you were to block it when it came in. But that third party breach that does happen, PHI is exposed to a third party perspective, which is reported. But what is kind of your downtime? What is your recovery? How are you going to be managing it? I think there's going to be more of that, right, than less of it, because as you know, healthcare is so target rich, and the ransomware that's being paid out there, I mean, it's breathtaking, in terms of there. So, I mean, I think from a health system perspective, you need to make sure that your cyber defenses are correct, that it is automated. This is another kind of AI ML conversation, right? That if something is detected, that it's isolated, that it's contained, that it's alerted onto a dashboard. Again, we've done a holistic overhaul of our GRC as well as our SecOps perspectives. And there's a consolidation really kind of happening in there to the big boys. We're a Cisco shop in there. So we have like tripled down to Cisco from an app ICE perspective, Ironport, et cetera, on the security stack that Cisco's provided, which has made it simpler. About 3 or 4 years ago, you probably had like 5 or 6 different vendors in your ecosystem that you were trying to intertwine and trying to make work well together. So I think, fortunately, right, I think it's gotten a little easier to consolidate into a particular vendor, but it really kind of depends on where you are in the space. And I think, the other part on that, again, on cyber is, people are our biggest risk out
Mm,
there. So people are being phished all the time, and it's going to happen, right? And somebody's going to click on it, but so what, right? What are you going to do? Is your system's going to contain it so it doesn't have outbound, which it should, right? Or is it going to let somebody in through the back door? So those are, kind of my points that kind of keep me up as well from a cyber perspective, because I can't control 5,000 folks. I can educate them, I can fish them. We can put all that information out there, but it just takes one bad actor, one compromised password, right, for the bad guys to get in. But the question is how to respond to it and how to contain it so there's no harm.
yeah. No, that's fascinating. Look at cybersecurity. The RCM side of things to me is super fascinating. It actually feels like the early days of internet redundancy. I don't know if
Yeah.
I'm sure you have the horror stories like me, where you're like, oh yeah, we have two redundant internet, sources. And then you realized, like they're unique here, but then here they combine, right? I mean, that's
Yeah.
kind of what happened with Change Healthcare. We thought we had redundant revenue cycle, but you're like, oh no, eventually it all ends up connecting. I wonder, that probably is an industry lesson more than an AltaMed lesson, I would think. But yeah, anyway, it'll be interesting to see how that plays out as well.
More to come for sure on that one, right?
Yeah, for sure. Well, we always like to end these with a little bit of career advice. You've obviously had a breadth of experience across a lot of organizations, and some unique organizations as well. So, what career advice would you give to someone who is maybe an aspiring CIO, looking to be the next most innovative CIO of the year, if you will?
Well, I think number one, you got to be curious, right? You just got to kind of like lean in and understand what's going on. I don't understand that. Go learn it. And I mean, I grew up on the application side. I thought I'd never be an infrastructure guy. I spent 6 years in infrastructure, and I thought I would never be able to talk about 4Ks, 6Ks, 2Ks, 5Ks, 9Ks. I know exactly what all that stuff does, around there. But I think really being natively curious is really important, not only from a technology perspective, but also from a business perspective. So understanding, the business, understand the processes they are. The innovative CIO is going to hear what's kind of going on and look for solutions that are out there. Listen to great podcasts like Healthcare IT Today to keep you kind of on the pulse in terms of what you need to know. And I think what helps being innovative is when that opportunity arises, right? You kind of already know what the space looks like, and you need to do some review in there. I think the other part on to be an effective CIO is you need to have good financial acumen. You need to understand profit loss, OpEx, CapEx, understand how money moves in there, how revenue moves through your organization. Again, you need to be people aligned. You need to be mission aligned. You need to be clinically aligned as well. So there's quite a bit you need to be aware of. But I think if you kind of put those together, I think I defined it before, the I in the CIO, because it can stand for information, informatics, it can stand for influence, and it can also stand for impact. So if you kind of keep those, at your core, you should be on to a good journey.
Yeah, that's good advice. Curiosity is a powerful, aspect across all of those areas, right?
Right.
As you learn and grow. So
right, and it's okay to say I don't know, right? Well, let me go figure it out, right? And that just makes you stronger, and it gives you more depth and lets you think multidimensionally.
Yeah, it's fascinating because when we say we know everything, no one can help you. But if you say I don't know, someone can help you learn, which I think is it's a mind change, a mindset shift for a lot of people.
Right, absolutely, totally.
Ray, this was a lot of fun. I appreciate you coming on and sharing your perspectives and your experience with us. And I know our audience is really going to appreciate it. And thanks everyone for watching and listening. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com or search for the CIO podcast by Healthcare IT Today on your favorite podcasting applications. Thanks, Ray.
Thank you. Bye.